1997, 8. So,
That's right. Ah,
yeah.
yes. Good days those were. Well, it's always been good days. Yes.
Fantastic.
But yeah.
Well, for the interest of time, will we just go on ahead and get started again? Happy?
Yep.
Yeah,
I'm
perfect.
happy.
So I have my camera on, yes. So I'm very pleased to introduce our next speaker, Professor Adam Balen. So Professor Balen is an NHS consultant with a personal chair of reproductive medicine and surgery. He is a member of the Global Guidance on PCOS, the WHO Infertility Guidance Group, and developed the FIGO classification for ovulatory disorders. Adam has also been a past chair for the British Fertility Society and has had numerous roles within the RCOG. And he's being very modest. He hasn't written this here, but he is actually up presently for president of the RCOG, and the ballot is currently open. In 2025, he was awarded the RCOG Academic Prize, the BFS Howard Jacobs Prize, and the BSG Alex Turnbull Prize. He co-founded the British Society for Paediatric and Adolescent Gynecology and the Fertility Education Initiative. Adam has authored over 300 papers with over 48,000 citations, and his 16 books, including Fertility in Practice, the 5th edition, published in 2022, and more recently, the fertility book, Your Definitive Guide to Achieving a Healthy Pregnancy for People Trying to Conceive. So we're very, very fortunate to have him in our programme today, and his presentation is on his overwhelming expertise on management of ovulatory polycystic ovarian syndrome.
Thank you so much, Emily, for that lovely introduction. It's very kind of you, and congratulations to the team, really, and particularly Mr. Abdul for having set up these amazing educational events. And thank you to you, Emily and Jay, for inviting me to talk at this reproductive symposium. So I think I sort of follow on hopefully quite nicely from that really great talk just given by Dr. Roger Stanworth on the management of type 1 anovulatory infertility, although I'll say a little bit about the WHO classification in a second. So I'm moving on really now to talk about polycystic ovary syndrome. These are some disclosures which don't really impact on the topic of my talk. And we've already heard the WHO classification mentioned, but I think it's important to state that this was never published as a peer-reviewed paper. The WHO produced some discussion papers back in the late 70s and early 80s, and they make quite interesting reading. But essentially, as we've heard already, there were 3 or possibly 4 classes based upon a combination of gonadotrophin and estradiol levels and also serum prolactin concentrations. We already heard group 1 described, which essentially is associated with low levels of gonadotrophins and a hypoestrogenic state, and in most descriptions also includes hyperprolactinemia. But some of the earlier descriptions, which essentially, as I said, were not in peer-reviewed papers, included hyperprolactinemia. Group 2 in the WHO classification is a real mixed bag. It's described as a gonadotrophin disorder with normal estrogen levels or hypothalamic and pituitary dysfunction. And whilst it's predominantly PCOS, it's quite a confusing group, really, and not easy to define. And group 3, essentially premature ovarian insufficiency with high gonadotrophins and low estrogen levels. So again, this sort of schematic diagram has been described, and just to put this in here to indicate again that PCOS comprises the majority of causes of anovulation, about 90%, with 5% being at the level of the hypothalamus and pituitary, and 5% or so being premature ovarian insufficiency. And as I've mentioned, and has already been mentioned, we see here that with PCOS, kind of anything goes with respect to serum gonadotrophin concentrations. And I'll talk more about this as we go through this talk. But the key distinguishing feature is that those with PCOS are not estrogen deficient. But I think there's some key considerations, and that is that hormone levels don't obey clear rules, and this has been alluded to already. So in type 1 anovulation, those with hypothalamic amenorrhea who are underweight often have serum FSH concentrations in the normal range. LH levels tend to be suppressed. Those with PCOS, FSH and LH are often in the normal range. It's only in about 40% that we see an elevated LH concentration. And for many people with disorders of ovulation, anovulation isn't absolute. So in other words, ovulatory dysfunction may fluctuate, and you see periods of time when there's a regular cycle. And for those, for example, who are affected by changes in body weight, then that can change the regularity of the cycle, and there can be periods of amenorrhea as well. So it's not always that clear cut, which is why a group of us decided that it was time to revisit the WHO classification and bring in a new classification that has now been widely accepted. This was published 3 years ago, and last year I published a very large review going through this in a lot of detail, essentially distinguishing hypothalamic, pituitary and ovarian causes of anovulation, and then subdividing them into this algorithm that I've written here, genetic, autoimmune, you can read it for yourselves, which apply to the hypothalamic, pituitary and ovarian causes. And then we've taken out PCOS because, as I'll describe for the rest of this talk, PCOS is a real mixed bag. It's complex pathophysiology, and so we've taken it out of this system and deal with it as a separate category. And so that's why we have this acronym HypoP, the hypothalamic, pituitary, ovarian and PCOS classification of disorders of ovulation. And this, over time, I think will replace the WHO classification because it was carefully considered. It is pragmatic, flexible, and we used the Delphi criteria and an international group of experts and involved patient groups as well to come up with this new definition. So moving on to PCOS, there have been many consensus meetings and guidelines over the years, and I've been very privileged to have been a part of all of them, from Rotterdam when we made the diagnosis back in 2003 to the WHO guideline, which has just been updated and shortly to be published, and the global PCOS guideline as well. These are huge pieces of work based upon detailed evidence. So this is the latest way from the global guidance that we diagnose PCOS. So we recognize the Rotterdam criteria as requiring 2 out of these 3 key features: a disorder of ovulation, either clinical or biochemical signs of androgen excess or hyperandrogenism, and or the presence of polycystic ovaries, but note that now we include an elevated serum anti-Müllerian hormone or AMH level as being a possible way of making the diagnosis, although actually there isn't a universally internationally agreed consensus for the cutoff of AMH for PCOS. And the key thing also is having to perform appropriate investigations to exclude other causes of menstrual cycle disturbance, other causes of androgen excess. Now, in the adolescents, and of course we're not talking about adolescents in the context of infertility, because many of the features are common, so adolescent girls have commonly irregular periods, you need to have both the presence of a menstrual cycle disturbance and hyperandrogenism to make the diagnosis. And so from a pragmatic point of view, If somebody has irregular cycles and clinical signs of androgen excess, and you've done appropriate investigations, which I'll come on to in a minute, that gives you the diagnosis of PCOS. If there isn't clinical androgen excess, then you test for a biochemical androgen excess. But if there's one or the other, so only irregular cycles or only androgen excess, then in adolescents, you can consider that they may have PCOS and you reassess them after a year or two, depending upon their age. In adults, you then do an ultrasound scan to look for polycystic ovaries or measure AMH to give you the diagnosis. Personally, I feel it's always useful to do an ultrasound scan, not only to look at the ovarian morphology, but also to look at endometrial thickness. So how do we define the polycystic ovary? Well, over my career, things have changed somewhat, but going back in time, before ultrasound, it was laparotomy. And I just put these in for historical interest, but also to show you that polycystic ovaries here can be extremely large in comparison with the uterus. And for many years, a wedge resection was performed, which is outdated and no longer performed. But this again illustrates these immature cystic structures, or the follicles that surround the polycystic ovary. Then transabdominal ultrasound evolved during the 1980s with real-time ultrasound, and then transvaginal in the 1990s. So at the time of Rotterdam, we diagnosed the polycystic ovary as having at least 12 follicles per ovary. These are immature follicles, usually less than 9 or 10 millimeters across. But with the evolution of better ultrasound equipment, we now suggest that a polycystic ovary has at least 20 of these immature follicles per ovary. Now, I mentioned AMH, this is our data. Susie Jacob did her research thesis with us. She's now a consultant colleague with me in Leeds, looking at AMH in a control group of women with polycystic ovaries and regular cycles, and women with polycystic ovary syndrome, in other words, having irregular cycles. And these are the cutoffs using our assay. And remember, there are different AMH assays, and this is measured in picomoles per litre. So whenever you talk about hormone levels, it's very important to know the assay and know the units of measurement, which of course will vary. Not everybody uses SI units around the world. So these are the cutoffs in our clinic, distinguishing those with normal ovaries from those with polycystic ovaries. But as I said, there isn't an international consensus. So these are the investigations I believe you should do if you have somebody, and Emily touched upon this in her talk, and it's just to reinforce, looking at their general health, in particular body weight. We tend to measure BMI, but it's a fairly crude assessment of fitness. And currently I'm leading a group to revise and relook at the British Fertility Society classification of obesity with respect to infertility. Check blood pressure, check glycemic status. Practically, we tend to measure the HbA1c. In research studies, we've done the oral glucose tolerance test. If you have the facilities, you can do a glucose tolerance test, but HbA1c probably suffices. Measure testosterone, which is the principal androgen. You don't need to measure the other androgens unless the testosterone is significantly raised, greater than 2 standard deviations above the limit for the assay that you use. So it is not necessary to measure these other androgens in our population. Some people measure sex hormone binding globulin, which I'll come on to again in a minute. It's the binding protein for testosterone. It's suppressed in those who are overweight with elevated serum insulin concentrations, and that amplifies the free androgen index. But it's an expensive test, so it doesn't need to be routinely measured, although it actually does correlate with impaired glucose tolerance, and also a suppressed SHBG correlates with an increased risk of gestational diabetes. So that's worth knowing. AMH, if you can, gonadotropins together with a serum estradiol concentration, and for completeness, a measurement of prolactin. Personally, there isn't great evidence that prolactin is elevated in those with PCOS, but anybody with an erratic cycle, you can consider measuring prolactin, of course, thyroid function, and then some basic assessments, full blood count, liver function. Often liver function tests are abnormal in those who are overweight, and similarly a lipid profile is worthwhile testing as a baseline. We always measure vitamin D, a huge amount of vitamin D deficiency, and many are low in serum ferritin concentrations as well, and you need to be replete when entering into a pregnancy. An ultrasound scan, as we mentioned, and then the routine preconception assessments that Emily mentioned so nicely in her talk, and of course not forgetting a semen analysis, and consider measuring or assessing tubal patency before starting ovulation induction. So the main driver for the elevated testosterone is LH from the pituitary gland, but it tends to be only significantly elevated in about 40% of those with PCOS, and those are usually the slim patients. For those who are overweight, it is insulin that acts as what we describe as a cogonadotrophin. The ovaries are not insulin resistant, unlike the muscle cells, for example, which are insulin resistant or do become insulin resistant. So in those who are overweight, who have high circulating levels of insulin, this acts also to drive the ovaries to overproduce testosterone, and also coexistently to suppress SHBG levels from the liver, thereby amplifying the free androgen index. And for many years now, I've had an interest in obesity, nutrition, and polycystic ovary syndrome going back over time. And this is an old study now, still one of, I think it might even still be one of the largest series of women with PCOS reported. And we clearly demonstrated that with increasing weight, there was worsening symptoms, a worsening endocrine profile, and this correlated with hyperinsulinemia. And if you can achieve weight reduction, you can expect to see a significant improvement in signs and symptoms, and not necessarily a total reversal of all of these features of PCOS, but certainly you would expect a greater likelihood of responding to any treatment that you want to give, and also better reproductive outcomes. We know that women with PCOS find it easier to gain weight and harder to lose weight compared with those who don't have PCOS, and this is for a number of reasons, which again we and others have looked into. So reduced postprandial thermogenesis, in other words, utilizing food energy less efficiently, a greater likelihood of disturbed eating patterns, abnormalities in the gut microbiome, which is an emerging and very fascinating topic, but still not fully worked out, disturbances in some gut hormones that also can affect hypothalamic function, changes in both visceral and subcutaneous fat metabolism, and a degree of insulin resistance that can also sometimes be seen in slim women with PCOS. We know that those who are overweight do less well when it comes to reproductive outcomes. Being overweight actually has a negative impact on both egg health and sperm health and the endometrium, leading to not only a reduced chance of conceiving naturally, increased risk of miscarriage, pregnancy complications such as gestational diabetes, obstetrical difficulties, maternal morbidity, and even mortality. And because of the Barker hypothesis, which I'm not going to go into today, this has an impact on the long-term health of children as well, and also is associated with an increased likelihood of some congenital anomalies. As I've mentioned, a reduced response to fertility treatment, and also being overweight may affect the safety of some of the procedures that we want to do, may make it harder to see ovaries on the scan or to provide safe anesthesia. This is a study that I published a couple of years ago with a group of colleagues looking at the UK GP database. This was at almost 19.5 million women aged between 18 and 45. On the GP database, 56,000 were identified as having PCOS. We know it'll be many more than that, and this just shows some of the deficiencies of the database. But in those who were identified as having PCOS, there are about 1,700 pregnancies over a 3-year period, and we categorize those women with PCOS into normal weight and the different overweight and obesity categories. And just to show you a couple of points here, so the chance of conceiving over time, over 3 years, you can see those with a normal weight, maybe 40%, with increasing levels of obesity, you see a significantly reduced chance of conceiving over time. Perhaps unsurprising, but this illustrates it quite nicely. Now, the chance of a pregnancy for a woman with a BMI of 35 to 40, you can see here on this curve, and this is age along the horizontal axis. So this is this obesity group, grade 2 obesity. You can see at the age of 31 is comparable to the chance of a pregnancy of a normal weight woman age 35. In other words, being significantly overweight ages you, or significantly reduces the chance of you conceiving. And both of these have half the chance of conceiving compared with a normal weight woman aged 27. So this is quite a useful pictorial way of assessing the chance of conceiving over time. Now, if you want to then look at change over time, those who lose a significant amount of weight have a greater chance of conceiving naturally. These were not individuals who were receiving treatment. And with weight gain, and these are all women with PCOS, you can see a significant reduction in the chance of conceiving over time. Now, there are many factors involved in all of this, and it's important that we're aware of emotional well-being. And together with Georgina Jones, who's professor of psychology in Leeds, we developed the PCOS health-related quality of life questionnaire. We developed this actually quite a few years ago now, and there's no doubt that emotional well-being is vital, not only for all of the symptoms of PCOS, but in particular to enable people to approach this and tackle these problems when they're trying to conceive. And we also see a much higher rate of eating disorders in those with PCOS, which amplify the endocrine abnormalities and also worsen the fertility outcomes. So women with PCOS are much more likely to have an abnormal eating pattern, 34% compared with 2.5% in the general population. This is research that we did a few years ago. So 30% have episodes of overeating and 4% extreme methods of weight control. So it's very important to try and gently ask these questions and provide appropriate psychological and nutritional support. We also see big ethnic variations in the presentation of PCOS, and Chandrika Wijeratne, who's professor of endocrinology in Colombo, Sri Lanka, many years ago now in Leeds, did her PhD with me looking at the South Asian population in the UK. And we found that they have an increased degree of insulin resistance and a worse phenotype at a lower BMI and a younger age than their white European counterparts, and had a lot of central adiposity as well, which correlated with the insulin resistance. And this has a significant impact on quality of life and reproductive outcomes. We also see quite a lot of disturbances in folate metabolism with MTHFR polymorphisms, which also affect cardiovascular risk, and a lot of vitamin D deficiency as well. So it's very important to measure folate, to measure vitamin D. Some people ask, why is it the case that a condition like PCOS, which is so common, is associated with subfertility? And we believe it's the so-called hypothesis of the thrifty genotype. In other words, those who have the genes that make it easy to gain weight actually historically benefited in times of famine because they sustained the population, because as we've heard already today, those who become underweight don't have the nutrition to sustain a pregnancy and become amenorrheic. So historically it's been helpful for some populations to have people who have a genetic ability to maintain weight during times of famine. But these genes now, with current lifestyle, sedentary lifestyle and overeating, conspire against us, those of us who have them, to make it easy to gain weight, harder to lose weight. If you're male, you'll present with type 2 diabetes and cardiovascular problems in your 50s and 60s. If you're female, you may present with PCOS, but there are other factors as well, and time today doesn't allow me to go into detail on the pathophysiology of PCOS other than to say there are environmental influences which may start as early as in the uterus. And of course, during adolescent life, it sets the scene for adult life with respect to nutrition, diet and exercise, and can be difficult to reverse. So the latest guideline does go into lifestyle advice in quite a lot of detail. So once you've done your appropriate investigations, have to advise a healthy lifestyle behavior. I don't believe that there's one particular PCOS diet. Healthy eating, the so-called Mediterranean diet, many people advocate and is certainly beneficial, combined with regular physical activity in order to optimize general health and reproductive outcomes. So this is a so-called multi-component lifestyle intervention with behavioral strategies and support as well. Now in the UK and the National Health Service, we often don't have the time to provide this in detail, but this ideally is what's required. And of course, making sure that we counteract the psychological factors and also advise about appropriate supplements, and for those who are overweight with a BMI of greater than 30, an increased folate of 5 milligrams as opposed to 400 micrograms, which is usually recommended. What about these other strategies? Well, a lot of people are interested in the various inositol preparations, which may have a moderate effect on improving insulin resistance, but there's no hard evidence from large randomized controlled trials. So in our latest guideline, we mention them, but we don't necessarily recommend them. The new drugs like the GLP-1 receptor agonists and the GIP agonists are successful in improving weight reduction in PCOS and generally. And this study published in the New England Journal just a few weeks ago now, comparing semaglutide with tirzepatide, actually showed that the combined preparation, the tirzepatide, which has both the GLP-1 and GIP agonist properties, 80% lose 10% and 50% will lose 20% of body weight, which is twice as many as those just given semaglutide alone. But these drugs are contraindicated in those who are trying to conceive because they may be teratogenic. They certainly are in animal studies. So we advise that those women taking these medications should be supervised and should use contraception. And there should be at least a 6 to 8 week washout period afterwards. And of course, there can be some rebound weight gain. Gastric surgery, so gastric bypass or banding, can also be very successful in achieving weight reduction, but it's very important to avoid pregnancy during the rapid weight loss that occurs afterwards and wait for at least 6 months for nutritional stability. And again, it's very important to have careful nutritional input. So we know that women with PCOS are more likely to have adverse pregnancy outcomes, which I've listed here. I'm not going to read them all through, but in particular, miscarriage, gestational diabetes, hypertensive problems, and increased morbidity. And so improving the situation preconceptionally has to be the first line. before moving on to managing the anovulatory infertility. And then we have the challenge of stimulating the growth of a single follicle from these multiple follicles in the polycystic ovary. And remember, we're usually dealing with 2 ovaries, and this is a 2-dimensional image of a 3-dimensional structure. And all we want is 1 follicle and the release of 1 egg in order to minimize the risk of multiple pregnancy. So this is the algorithm that we developed in the global guideline for the management of infertility. So we diagnose PCOS, as I've described, optimize preconception health, and then the first line medical treatment is this central pathway, with letrozole being first line therapy and some alternatives that I'll mention briefly. The key issue is if we detect ovulation, then repeated cycles. We usually suggest 6 ovulations, and if a pregnancy hasn't occurred, then one moves on to IVF. If ovulation isn't occurring, then we move on to second-line therapy, which I'll come on to in a minute. So letrozole first at increasing doses. So historically, clomiphene was used, clomiphene citrate, which is an anti-estrogen at the level of both the pituitary and the endometrium, which can be detrimental. And we don't have feedback preserved when clomiphene is administered. So you often get hypersecretion of FSH and LH and at least a 10% multiple pregnancy rate. And for those who hypersecrete LH when given clomiphene, the outcomes are less good. Letrozole acts at the level of the ovary, inhibiting the conversion of testosterone to estradiol. Feedback is preserved, and there isn't a detrimental effect on the endometrium, and you're more likely to have monofollicular development. And so it has been shown in a number of studies now, and this is from the global guideline, a meta-analysis, a forest plot of the large RCTs showing that the odds ratio of a live birth, and of course it's live birth that is important, significantly favors letrozole when compared with clomiphene. So we start with 2.5 milligrams for 5 days, usually on day 2 of the menstrual cycle. You can increase to 5 or even 7.5 milligrams if ovulation isn't occurring. And then multiple cycles. We monitor with ultrasound to confirm that ovulation is occurring and to confirm that there isn't an over-response. Now, there are alternatives. Some places letrozole isn't available or licensed. It is in the UK. You can use clomiphene either alone or with metformin. Combined with metformin, the outcomes are better. You can actually go straight to gonadotrophin injections if you want. They actually work well as first-line therapy, but they require monitoring and they're costly, so we wouldn't usually go straight to gonadotrophin therapy. This again, I'm not going to show you lots of meta-analyses, but this is metformin versus placebo showing an odds ratio for live birth. So even metformin will achieve some pregnancies, but it's not actually a drug that stimulates ovulation. So if ovulation is not occurring, so if ovulation is not detected, we move to gonadotrophin ovulation induction with ultrasound monitoring. And we use low-dose regimens with very careful monitoring, and we will only administer HCG. So we have to give HCG to trigger ovulation. HCG is the surrogate for LH. HCG is almost identical to luteinizing hormone, and we administer it. You can give LH if you've got recombinant LH, but HCG is cheaper. We give HCG to trigger the release of the egg when we have 1 follicle. Our protocol doesn't allow more than a total of 2 follicles greater than 14 millimeter. And remember, this has to be both ovaries combined in order to, well, we allow twins, but we prefer a single ovulation. And this is an old study now, but this is in patients who did not ovulate in response to clomiphene. You can see with gonadotrophin therapy, you get very good cumulative conception rates over time. You can also predict the chance of ovulation and a live birth with gonadotrophin therapy. This is a Dutch study from a few years ago now. So if I take you through this, they use the free androgen index. So with an elevated free androgen index of almost 7, a BMI of 20, you'd expect a 90% chance of ovulation. So with a 90% chance of ovulation at, say, age 30, you'd have a 30% chance of a live birth with one cycle, remember just one cycle of ovarian stimulation. Conversely, if you have somebody with a similar free androgen index, but they have a BMI of 40, now we wouldn't treat somebody with a BMI of 40, but they would then have a much lower chance of ovulation, maybe 35%, only a 10% chance of a live birth. So this just illustrates what one might expect from ovulation induction. Now, an alternative to gonadotrophin therapy is ovarian diathermy or ovarian drilling. It's important to use minimal damage to the ovaries. Bipolar diathermy preferably. Some people use monopolar. There's a low risk of multiple pregnancy, but it does take longer to conceive and often requires the additional use of ovulation induction therapy. So it's not something that we offer that often, but it has a utility if you need to do a laparoscopy for another reason, or for those who find it difficult to travel to clinic for regular ultrasound monitoring. So if you look at the chance of conceiving using gonadotrophins compared with ovarian diathermy, you have more than a 2-fold odds ratio, so a much greater chance of conceiving with gonadotrophin therapy. The advantage of ovarian diathermy is you have a much higher chance of a multiple pregnancy with gonadotrophins compared with ovarian diathermy, although I would argue if you monitor very carefully, you should be able to keep, and if you have strict criteria for HCG, you should be able to keep multiple pregnancy rates low. So repeated cycles of ovulation induction, and then you move on to IVF, and IVF is third-line medical therapy. I'm not going to say anything much about IVF today, but remember that some people with PCOS or polycystic ovaries without the full-blown syndrome may require IVF because either their male partner has a low sperm count or they have blocked tubes. And we have to remember that those with PCOS are more at risk of ovarian hyperstimulation, so we have to use specific protocols to minimize the risk of OHSS, and often we're freezing the embryos electively, and I'm sure that will be covered in a later talk. So today is really about ovulation induction for PCOS, not for IVF, but those with polycystic ovaries have to be very carefully monitored if they do require IVF with specific protocols as well. So just leave you with a couple of plugs. First, the fertility book, which together with my wife, Grace Dugdale, we've written for patients wishing to conceive. This has a lot of information about the evidence behind supplements, diets, and practical ways of improving reproductive health for both women and men. And the 5th edition of my fertility book, which covers it covers all of what I've just said, and many other aspects of infertility practice. So I will leave it at that, and happy to take questions.
Oh, that's fantastic. Thank you very much, Adam, for such a fabulous lecture with a lot of pragmatic points, with a clinical approach, and that helps us in managing PCOS quite well. And that too supplemented with all the evidence base, and most of it is from you yourself, and that is great. And it is a great privilege to have you. And thank you very much for
thank
coming
you.
and speaking.
Thank you.
So we have a few questions. So if that's okay with you, Joanna Gatto, do you want to switch on the camera and ask the question that you want to ask?
Hello, good morning. Thank you for your talk. My question is about the new classification and diagnosis. And the reason why I'm asking this question is because it's not infrequent that we get women in gynecology clinic saying, I have PCOS and diagnosed a few years ago. We have no access to any of the investigations. And yet, say, for example, they have only raised androgens or hirsutism or something like that. And then we end up doing a scan that shows no polycystic ovary and their cycles are regular. So then they have this historical diagnosis of PCOS that we can't get evidence for. But according to the Rotterdam criteria before, they would not now be classified as PCOS. And it's my understanding that PCOS is not really a curable condition. So my question would be, with the new classification, should we in these women then opt to measure the AMH as a surrogate for the absence of polycystic ovary on scan?
That's a very interesting question, and if they have normal ovaries, their AMH is likely to be normal as well. And you're right in a sense in when you say PCOS isn't curable, but PCOS is modifiable, and as women get older with PCOS, the cycles often regulate because the natural change in ovarian follicle number declines. And so women with PCOS often do find, as they get into their late 30s, early 40s, that their cycle naturally regulates. So I would never dismiss an earlier diagnosis of PCOS, and I tend to take a pragmatic approach depending upon what the symptoms are and what that individual needs and requires. So I agree with you. We do see this quite commonly. I think, and I'm always very cautious. And of course, when our patients have it in their minds that there's been some diagnosis given, it's very important not to rock the boat and cause them to feel concerned that maybe a misdiagnosis was made, because it probably was an appropriate diagnosis at the time, but things have changed over time. The other thing, of course, to say that those with PCOS have an extended reproductive life span, interestingly, because they have a greater inherent follicle pool, so they are fertile for longer. And when you look at epidemiological studies, those with PCOS often do have their desired family size, but it may take them longer. But I think that's a really important point that you've made. And I tend to take a pragmatic approach, and also to appreciate that one size doesn't fit all, to coin a phrase, and you can have what I would describe sometimes as mild PCOS. And some people have tried to sort of subclassify the different phenotypes, because I think, there's a spectrum. Not everybody has the full house, and things can change over time.
Thank you. I don't know if I could add something, a layer to this, if that's okay, because I am thinking about a particular patient that I saw a few years ago that had amenorrhea for 2 years. She was only about 27 years old. So secondary amenorrhea for 2 years, not pregnant, by the way, ever, in those 2 years. But she was really severely obese, and her weight was going up and up. But all the hormonal panel that we did for her was all fine. It was all normal. Granted, we did not go into cortisol and things like that, which was one of the things I thought about. But the scan was also normal, showing no polycystic ovary. So then, wow, but there's this one ovulation abnormality and this really raised BMI. And at the time, my consultant was suggesting it could be PCOS, but again, it did not fit into the criteria. So.
Well, interesting, because there are other causes of there are some causes of extreme obesity that have hypothalamic, and again, it's subtle and can be different. I mean, what I would do is look at the endometrium. I mean, was her endometrium thick or thin? Okay, because if you have prolonged amenorrhea with obesity, then you'd expect the endometrium to be thick, and that's that. And as Roger mentioned in his talk, it's the estrogenization, and looking at the endometrium is actually quite useful. And of course, PCOS is common, but other things are common as well.
Yeah.
So don't forget other conditions. And I didn't talk about the full spectrum of PCOS because today is about infertility. But of course, we have those with PCOS who have alopecia, and it's not only due to androgens. Sometimes it's due to low ferritin. It can be due to celiac disease, is very common. So always, think of these other things that can coexist, because PCOS is common, but other things are common as well, like thyroid dysfunction. And if you have a thyroid dysfunction in the autoimmune spectrum, you have to think about things like celiac, poor absorption of nutrients. All of these things have an impact.
Thank you so much.
Okay, thank you. Uzma wanted to ask, Uzma Safar, would you like to ask that question? Seems to be very practical.
Yeah, just wanted to know if we can start letrozole in our DGH setting. It's not something which should be done under a fertility specialist or a fertility specialist clinic. Thank you.
I think you probably could and should. I think that's an interesting question, and I suppose you'll have local guidelines as well. Certainly in Leeds, we have a hub and spoke with our colleagues in the local DGHs who do prescribe ovulation induction with letrozole. Don't always have full accessibility to ultrasound. The risk of multiple pregnancy is relatively low with letrozole, but if you start with a low dose, if you can provide some form of monitoring, I think that would be appropriate. But if you feel comfortable, I think that's absolutely fine. And the other sorry to interrupt you. The other thing to say is that once we've confirmed that ovulation is occurring, we don't suggest ovulation monitoring with ultrasound every cycle. So we will give them a few cycles to just do at home and maybe do home monitoring. Sorry, you were going to ask something else.
No, I was just going to say, because we do historically were giving clomiphene citrate, so it's a kind of, now we have got another first line therapy which is better than from side effect point of view, it's better than clomiphene. So I can't see why we can't, although I don't think we have any guidelines locally. In DGH, unless you have a specialist fertility clinic, you wouldn't normally have those guidelines, and it's just your clinical common sense that you use to prescribe those medications, which you should be able to justify why you prescribed something. So just wanted to know if it is prescribable in a DGH setting where you have been prescribing clomiphene citrate.
Well, the straight answer is yes. I think you should and
Thank
could.
you.
And again, I know things vary, and Emily touched upon this in her talk. Things vary around the country, but in Yorkshire, we have the West Yorkshire and Humber sort of axis with in which we have our funding guidelines. And also that covers the treatments, and as I said, the hub and spoke, and I'm sure you can link in with your sort of local sort of tertiary referral centre to ensure that you both, that you harmonise on the guidance. And you can always refer to the BFS and the ESHRA, WHO guidelines, all of which put and NICE, of course, now put letrozole firmly as first line.
Yeah, thank you very much. Thank you.
Thank you, Adam. Somo Hutun, do you want to ask your question?
Yeah. I just want to ask, we often see PCOS patients with very high BMI, and they also very struggle to lose weight. And they do research, you show that using Mounjaro, Ozempic can reduce weight, could potentially improve fertility. Should we start using them, or I don't know whether it could be the game changer for those ladies with high BMI to get pregnant and lose weight?
I think you're right. It is a game changer, but and the question is who prescribes. So personally, I've never prescribed. I have suggested that people seek the support of their GP, but of course we know that there are funding restrictions, and the UK government is looking at this. But yes, I think it is a game changer. The proviso, as I mentioned, is that we should avoid pregnancy. And in fact, there was there's often publicity. I think there was some publicity yesterday about this as well. Avoid pregnancy whilst taking it. But it's the weight side of things is a real issue, and we need to sort of tackle this. The whole issue of obesity on a more population and global level. I mean, you raise a very important point.
Oh, because we're seeing those medication, even from online pharmacy prescribing those, or whether as like obs and gynae, whether we can recommend patients going to those if they're able to afford. Because they
I tend to duck out. Yes, I tend to duck out of that. I'm cautious and would advise against people getting things online. I mean, things should be, because there are obviously side effects and risks, and some people actually have experienced bad side effects. So I would always suggest that any powerful medication should be prescribed in the context of medical supervision, particularly these preparations, which are still relatively new.
Thank you.
Great. Well, thank you very, very much, Professor Balen, for such a fantastic talk. We really appreciate your expertise. So our next speaker today is Dr. Joanne McManus.